again welcome Fulbright scholar from Uganda, John Paul Agaba, who is a public health specialist. He is also an attorney who basically has devoted his life to trying to improve his nation's public health. That's a pretty big responsibility. And he is, first of all, also currently teaching. He's a Fulbright scholar in residence at the College of St. Rose in Albany, New York. And he was viewed as being quite valuable. So a neighboring college, Regis, I think it's in Massachusetts, they nabbed him too. So currently he's teaching at both campuses. So that's a pretty heavy load. But the idea is, as I shared with students at Montcalm High School yesterday, and also at James Monroe High School yesterday, we learn, we grow, and then we share, and we help others. And it's all about human beings. Whatever it is you are learning today, it's all about giving back to your fellow human beings, making sure they're all functioning okay. And that brings more meaning and more value to whatever your chosen professional career might be. So helping your fellow man, that's the basic thing here. And if you don't see yourself helping your fellow man down the road, rethink what it is you're doing, because you really want to be helpful to your fellow man. Okay? So, having said that, here's a man who lifts people up.
Thank you very much, Dr. Jani. It's beyond words for your description of myself. It's always good when someone else is introducing me because they do more justice than you would have done yourself. I'm pleased to be here. I come from the College of St. Rose. Back home, I come from a small university called Kisuri, where I do part-time teaching. My background has been more in legal representation of forced migrants within Uganda. We have close to a population of 2 million refugees in Uganda who come from the Great Lakes region. So I started out working with an organization called International Medical Corps. It's a US-based charity, kind of related to MSF, or Doctors Without Borders. It's more common, but it's a US kind of chapter. And we're doing more of the reproductive health interventions, health rights, sexual and gender-based violence programming. And through working over the years for close to 10 years with the organizations, I delved into public health. One of the things that kind of triggered me to join public health, we were running an HIV program called PEPFAR, a presidential initiative from the United States. And there was a program called PMT, Prevention of Mother Transmission of HIV, kids, newborns, and the rest. And I had this staff member of mine who was a community health volunteer. She was HIV positive. She was part of key people in the community, but she never took her medication. And I got to know later on in the program that whenever she picked her medication, she would throw it on the way. And it wasn't only her, most women were doing it. And it went beyond couple disclosure. It was the relationship between the men and their women within the household that affected their adherence to drug uptake. So I was like, how do we involve these men in this program? How do we get them to think the other way? And we started a program called Male Involvement in Prevention of Mother-to-Child Transmission. And most of our initial programs were how do we involve men. We went out, looked at other programs, and basically they were just get them to the hospital, get them to the antenatal clinics, let them hear what the rest have to say. We did it, and the way we were getting the men in was a reward system. A man comes with the wife, we give them a t-shirt, give them an umbrella. Smaller as it was, it attracted very many men to come for antenatal care, come with their wives. But then, they sat at the trees outside the hospital and never participated. Basically, they were coming for the umbrella and going back home. And the trend continued. After 2 years, the evaluation was like, basically no work done. Then we changed strategy to kind of get male role models, involve them, train them, and then they would go to bars, to their fellow colleagues in homes, and it developed into what we later on was called home-based care counseling and testing. And that shot up. We saw a lot of impact after involving the men. And that was my study as well at the Masters in Public Health. So that background describes how we joined public health field to date. And so I'll be talking about Uganda. Uganda is a country in East Africa. We're part of the East African community. Currently, we are 5 nations in the East African community. And we're trying to federate, economic federation. I don't know how far we'll go because our examples we get from our colonial masters, Brexit. So I think it won't hold. There are already challenges on the federation from examples of the other European Union federation. So today I'll basically tell you briefly about public health challenges in Uganda, but with more of a bias on safe motherhood, because that has now become more of my passion. Because in Uganda we lose 340 women per 100,000, so roughly around 60 women die daily as a result of maternal and child health related issues. So, can we begin by... And technology feels it's not changing.
Go ahead. You know how to do it? Anybody know how to handle that?
Slide with it.
The technicians have run away. There you go.
Thank you.
Thank you, Austin.
So, a bit of the demographics of where Uganda is. Notice where the other countries are trying to join the Federation of East Africa. And we have close to an area of 94 square miles. I just try to make a comparison with West Virginia because the biggest assumption back home, we assume the US is a country. So everything examples we get of, the US is doing this, what are we doing in Uganda? But the reality that I even was sharing with my host is that the first time I came to US, that's when I noticed the US is a continent. It's not a country. So in comparison with West Virginia, which is 24 square miles, we have a total population of 44.7 million people. West Virginia has 1.8. Our GDP is about 25 billion US dollars. whereas West Virginia is 67. Already you can see the huge population, GDP, the demographics already tell we are part of the least developing country. Currently, we're at the verge of being developing. The IMF still categorizes us as least developing. Our maternal mortality deaths are that big comparison to got this on the website, I said 12. West Virginia looks to be like one of the states that has the highest in the US. Life expectancy, if you're a guy, you'll probably live up to 60, and female 65. Still, most of the statistics, with my comparative statistics, I got them online from one of the websites. So I noticed that the US average is 80, West Virginia 74, 78. You'll fact check me if I'm wrong. So we have a population growth of about 3.4 per annum. This is one of the reasons is our high fertility rates. On average, our fertility rate is every woman will give birth to 7 kids. Not looking at even the numbers are enormous with the teenage pregnancies. And the burden is associated with poverty, early marriages, and all that. We have a HIV prevalence rate of 6.4. Uganda was one of the countries that had an HIV prevalence in 1986 to 90 of 32%. So efforts, global efforts, and energies have helped out reduce this prevalence to 6.4. Of the 6.4 is the average. The unique thing is within the married couples, it's 7.5. So that clearly talks about the attitude of who are now more cautious of HIV and who are just out there and don't care. But one of the stereotypes is if you basically are 40, you have 20 years to live. With the drugs, now you can live up to 30. So most married couples become more promiscuous because the life expectancy is short. Most of them are like, well, I've had my kids, I can do whatever I want now. I'll get on the drugs and live long. And that has changed the projectile. We had gone as low as 5, and that currently is changing. Our infant mortality rates are 76 per 1,000. Goes without saying, high mortality, maternal mortality, high infant mortality rates. Under 5 mortality, 1.5, 157. Most of the cases are related to diarrheal diseases, very preventable diseases, but because of the poverty and all that. Our doctor-patient ratio is 1 to 300,000. And this is an estimate that is way up there. The reality is that some districts have no doctor at all. The farther you go out of the city, the less health professionals you'll find. The health professionals concentrate within the city centers. Our GDP expenditure on health, 7.2% of our national budget. Our national budget, which is 40% funded by donors and the rest of the world. And 60% is on defense. I don't know what we are defending a lot, but it tells the attitude of our politicians towards the needs and realities of the community. and how they impact on the rest of the community. So we spend about $15 on average per capita on every individual. Well, I believe most of you are science students. I won't delve into the definition, just put it out there. Just briefly to look at the health systems. Back home, the tradition has been more of you seek health care from hospital. The preventive medicine wasn't there at all. It's only now that public health is coming out, pushing people to prevent diseases, and infectious diseases have played a role in creating awareness that, oh, when you have Ebola, you have to keep clean, you have to bury people early, you have to avoid customs of washing body. And now, it's kind of a double-edged sword. People are more aware when we have serious infectious diseases happening. Our health care system, well, don't be fooled by the fact that we say our healthcare system is free. Our government will probably tell you health is free in Uganda, you can seek help in the hospitals. But like since the UN system started pushing for the MDGs and SDGs, some political moves have been put out there just to appease. Like we have a universal education system for primary kids. The fact it's universal and free, and most people now, there's a joke about it that it's free and free of education. So there is no learning. You just get kids in school and they finish grade 7 without even the ability to write and read. Like you get the statistics and they say, oh, you're closing the gap. So our healthcare system, even in the government hospitals, you pay. Most of what you will get will be free diagnosis. But after that, you pay for that. Education, you pay to get on one of the hospital beds, which are few. It's not uncommon if you went into the maternity ward of one national referral hospital, find people sleeping on the floor, delivering on the floor, midwives delivering like 5 women that are going less than 30 minutes in there, and then jumps out, moves on to the next. So the way it's organized, structured, we begin at the village level, and most of what is there are private clinics. Private clinics by nursing aides who have been in the health sector for long. Go to a village and start up a small clinic. Others are traditional systems like the traditional birth attendants who provide a lot of maternal health services. At one point, the global WHO standard was make sure you deal well with traditional methods of giving birth, what's increasing your maternal mortality rates. But the fact was there were no structures put in place. So most women still went to deliver from the traditional birth attendants. So those are most of the players at village level. At parish level, most are private, non-for-profit. Missions, the traditional mission hospitals, Catholic mission hospitals, faith-based hospitals are the ones that provide most of it. Still, you pay, there's a cost share. If you're attending a clinic, you pay some portion. So that's majorly at health sector. And these run concurrently with the government. The government will say we have a health center 1, health center 2, but it's not private. much as structurally they say it's free. Rather, it's not free. It's not public, like you go and seek help. We have no health insurance policy at all. Only for a few private companies, international corporations that provide health care. We have a health center, 3, still most private medical practitioners. Now there we get a bit of qualified people at health center 3 level. Within the government institutions, we have a doctor at each sub-county, and the joke is that the doctor comes on Monday, goes to his private clinic, and the hospital, he hangs his coat, and goes, and comes back Friday to pick his coat. The hours he provides at the health center will be referring you to his clinic in the afternoon to go and get the actual treatment. So there's that kind of mismatch. And because the government can't pay you well, you provide, you source other modes of income. So you're both in government and both in private. And it's acceptable in Uganda to be a medical doctor in a referral hospital and have a clinic next to the hospital. At health center 4, the numbers increase. These are now what we would call county level. The structures aren't, if you're used to the British system of administration, the structures move upwards, and it only applies for referrals. And because the lower levels have very little they provide in healthcare, the main healthcare begins at the district referral hospital, where you'll find a big referral hospital with all structures. But still likewise with all the corruption and that, you have a private wing within the government public hospital. The best doctors are in the private wing, and they work on the other side as well. So chances of you getting health care from the general wing is close to 0. We have community health workers, and the National Referral Hospital, which is Mulago, is a teaching hospital, has very many professionals, and still it's private, public but private. I just want you to get that distinction, because it's not entirely free. You pay cost share. So if you're living below $1 per day, which is close to 60% of the population, and you have to pay tells most causes of mortality, HIV/AIDS still ranks highest, malaria, lower respiratory infections. In comparison to the US, you notice that most of our burden of disease is infectious diseases. We have, in comparison to the other developed world, where now they're more progressive to the non-infectious diseases. Vaccines are still a problem. We still, through different international organizations, there's support. For example, for hepatitis, getting a shot for hepatitis will cost you about $10, and it's phased. So majority of the population can't afford it. So what are most of the public health challenges? Poverty and limited resources. It goes by default that if you're poor, you have less chances of seeking help. The health disparities increase with poverty across the globe. I've noticed even in the US, the poor communities have low health seeking behaviors and poor infrastructure. There are communities where we still use, call it the helicopter method of transferring women who are almost giving birth. The helicopter is basically stretching. Put the lady and you move to the nearest road, main road. And it's only of recent that there have been kind of technical adjustments. The bikes, we've had an adjustment on the put an attachment, kind of a bike ambulance. But there are spots where a bike ambulance won't even get to. So most women, one of the delays that lead to maternal mortality is that delay from the home to the health facility. Unreliable community involvement. It goes without saying that most of our politicians are out there to get rich. So currently the middle class is, if we look at, we got independence in 1962. If we look at the middle class then, from 62 to the 80s, even with all the conflict, the middle class was close to 40%. Currently, the middle class has been wiped as thin as 5%. So you have the very rich and the very poor. You have the politicians who, when the daughter wants to deliver, will get a presidential private jet to deliver in the UK hospitals, whereas the rest can't even afford an oxytocin to just prevent donor dependency. Recently, about 2 years ago, we had a political standoff with the rest of the international community when one of our politicians became so zealous and tabled an we'll call it the anti-homosexuality bill. And he was playing on the whims of the faith-based organizations and the fact that most of our community is religious. The moment the bill was passed in Parliament, the Irish cut aid. The UK followed. Within a week, the response towards HIV had dropped. There were no more drugs, no more medication, ARVs going out to the different health centers. And lo and behold, sense got back to our leader, and he revisited the bill. And it's now normal and shelved. But that goes on to explain at times why priorities are different from what the community wants. If the global trend is, say, heart disease, and the global burden is shifting at the international level, it builds on onto smaller economies in relation to funding. We find most of the big money now is coming from private donors, Bill Gates and all the other private donors within the global north. Corruption, simple example, put your jacket and walk off to your private hospital, and the corruption goes beyond. A lot of brain drain. Most of, if you look at the CBC centers that are trying to respond to Ebola in Congo currently, HIV/AIDS research, it's a fact that most of our professionals tend to end up in the West. If you're being paid, a doctor earns about $500, and you have a politician who even isn't educated earning $3,000. That brings a lot of disparity and pull to the Western world that most doctors, most professionals leave and come to the West. world health leadership, the healthcare is a mess. The corruption worsens it. Low-level budgeting on drug stockers. So this is the organization I work with for the urban migrant population in Kampala. Do a lot of legal representation and human rights advocacy, economic empowerment, education tours and investments for students from the UK, US, and research and consultants. This was a group from the College of St. Rose that visited and took them around. So we have programs of student placement, place you within different healthcare systems and get experience of what happens on the other side of the world. Thank you. I just wanted to, because I wasn't 5 minutes, I didn't have time to share. So it's not all doom and gloom in Uganda. Uganda is just unless our tourism is the second largest contributor to our economy. So if you ever want to come and visit, this is what
wonderful new world.